Hello, my name is Nicole Jeffemans. I'm a critical care physician from Amsterdam, the Netherlands. And within this session on issues in massive transfusion, I'm going to talk to you about transfusion and the microcirculation. These are my disclosures. None of them are relevant to this talk. And I think the most important disclosure that I have is that the issue of connecting the microcirculation to your resuscitation practice during massive bleeding is quite experimental at this time. So it's a difficult question, what happens to the microcirculation during hemorrhagic shock. And I've tried to dissect this question in three parts. So first, during hemorrhagic bleeding, what happens to the microcirculation? What effect does the transfusion have on this microcirculation? And can we integrate these data into our practice of resuscitation strategies? So shock is a deficit of oxygen in the tissue. So the demand is higher than the supply. But the way that we define hypovolemic shock is by describing cardiac output, blood pressure, vascular resistance, preload, and none of these, they relate to pressure and volume, but none of these measures actually point towards an oxygen deficit at the cellular level. So these parameters are not integrated into this definition. So there seems to be quite a disconnection between the parameters that we use to describe hypovolemic shock versus what is really happening at the tissue level. So let's take a look at the tissue level. What are the microcirculatory responses when you become when you have shock due to bleeding? Well, normally this is the arteriolar tone, and this within this divides into the capillary beds. And you can see here that there are various capillary beds with various densities of red blood cells. So there's heterogeneity in the red blood cell flow within the capillary bed. And this is normal. And why does this happen? This is because there are tissues that have a high oxygen demand and tissues that have a low oxygen demand. So the capillary bed tries to meet these demand and supplies by regulating the density of the red blood cell perfusion within the capillaries. What happens during shock? Under the influence of nitric oxide, there is a vasodilatation, there is recruitment of the capillaries, so there are more. And you can see that this heterogeneity of red blood cell flow sort of disappears. So all the capillaries become perfused at the same time. And also there is a decrease in the distance to the mitochondrion in the cell. So these are physiologic changes that the body does in trying to respond to this shock. The other thing that happens is within the red blood cell. So these are a little bit complicated pictures. What I meant to say here is that in response to hypoxia, the red blood cell starts to produce ATP, and this ATP then induces local vasoconstriction and vasodilation. And here is another theory or mechanism that may be in place in red blood cell changes in response to hypoxia, and that is that NO changes the hemoglobin conformation. So the hemoglobin molecules changes shape, and thereby it can also influence the vascular tone. But regardless of the mechanism, both of these effects that hypoxic tissues become vasodilated, and thereby the perfusion of those tissues in need of oxygen becomes increased. And this is also, well, an endogenous response of the body trying to counteract the effects of shock. But despite these adequate changes of the body, there can be microcirculatory derangement in shock. And here you can see that, well, there is a recruitment of capillaries, but some of the capillaries are not perfused at all, so no red blood cells there. And in other capillaries, there's aggregation of the red blood cells with obstruction of the capillary. And all in all, there's a decrease in capillary flow, and there's an increase in heterogeneity of blood flow, with some not perfused at all and some a little bit sluggish. And this is due to the red blood cell deformability occurring during shock. So what happens during hemorrhagic shock? And this has been shown in a sheet model. What happens to the microcirculation? First, let's have a look at the cardiac output. In shock, this decreases, and this is associated with an increase in lactate. So there is shock going on. What happens to the microcirculation? And here you can see the microvascular flow index with use of a handheld camera under the tongue. And there you can see that under the tongue, the microvascular flow index is also decreased, as well as the flow index in the gut. So, and these changes in the microcirculation, they sort of mimic or follow the change that you see in cardiac output. And this is not all the case in all forms of shock. Here we take a look at two forms of shock, so hemorrhagic shock and septic shock. And we are looking at the red blood cell velocity within the villi in the gut. After the villi, the red blood cells have been labeled with the fluorescent marker. So what happens here if these animals become hypotensive, you can see that the red blood cell velocity within the gut is severely compromised in sepsis and septic shock, but not so much in hemorrhagic shock. So again, hemorrhagic shock follows the macrocirculatory parameters, whereas there is a sort of dissociation with what happens in the tissue versus the cardiac output in septic shock, but not so much in hemorrhagic shock. So what effect does the red blood cell have on the microcirculation? Again, we turn to the experimental condition in a hemorrhagic shock in rats, in which hypotension was induced, and then these rats were resuscitated with crystalloids. Well, what happens? The lactate decreases, but the saturation of the kidney does not, so it doesn't improve. So thereby, fluid resuscitation does not improve the oxygenation of the kidneys. What happens if you transfuse these rats with blood, with rat blood, so animal blood? The lactate drops, and also the tissue saturation within the kidney improves. So thereby, yeah, this red blood cells also have an effect on the tissue saturation. And here you can see the measurements. So this is the PO2, so the oxygen tension within the microvasculature of the kidney. You can see that it decreases during shock with fluid, that nothing much really happens, and after it's transfused, it comes back to normal. So what about hemorrhagic shock in animals that are transfused? Here again, you can see that there's an increase in the cardiac index, and this correlates also with an increase in the microvascular oxygen tension in the gut as well as in the heart. So important organs, and again, these microcirculatory changes also follow the macro hemodynamic parameters. Do we have clinical data? Yes, this is data in patients undergoing cardiac surgery, receiving blood cell transfusion, in which measures of the microcirculation were measured before and after blood cell transfusion. And here you can see the vessel density plotted here and the vessel length plotted here. And both of these parameters increase or improve after a red blood cell transfusion. So can we integrate this into our transfusion practice? And is this relevant? Yes, it is highly relevant, because this is the microcirculation of a survivor of a septic shock, or of a hemorrhagic shock, and this is a non-survivor. So you can see that, well, improvement of these microcirculatory flow is associated with survival. So what is the effect of red blood cell transfusion on microcirculation in patients? This is a little bit of a difficult graph. I will guide you through it. But of note, this pertains to anemic ICU patients who were not having a hemorrhagic shock, because of course it's a little bit difficult to measure the microcirculation during hemorrhagic shock in patients. What you can see here is the proportion of perfused vessels. So again, the vessel density. And here you want to see an increase. So thereby this is good, and this way it is bad. And here the PPV is depicted as relevant to the baseline PPV. The baseline PPV here is normal, and there it becomes deranged. So you can see here that the red blood cell increases the PPV when baseline PPV is low. And the same holds for the microvascular flow index, which is another parameter. So if your baseline microvascular flow index is low, then you will see an improvement of the red blood cell transfusion. So this has been shown recently by our own group and also in another group with a very similar graph here. Again, showing the same thing, that the improvement of the microcirculation following a red blood cell transfusion depends on your pre-status microcirculatory index. This may be a little bit difficult to implement during hemorrhagic shock. Another finding that we have is that the effect of the red blood cell transfusion is also dependent on your disease severity. Here depicted as the sequential organ failure assessment. So the more severely ill, the higher the SOFA score. And you can see here that in patients with a high SOFA score, if you give a red blood cell transfusion, parameters of the microcirculation improve, whereas if you have a low SOFA score, in other words, you're not that ill, the microcirculation decreases following red blood cell transfusion. And of note, all these patients received the red cell at a hemoglobin level of around 7 grams per deciliter. And here you see the correlation. So I think this is important information. The question is how to integrate this within your transfusion practice. I guess it makes the case for not only using hemoglobin, but also parameters of the microcirculation. But of course, how this relates to massive transfusion is still not yet ready for clinical practice. So with this, I would like to conclude by saying that during hemorrhagic shock, the microcirculation parameters follow those of the global hemodynamic derangements. Fluids do not improve tissue saturation, but blood does, and thereby blood may not only be a carrier of oxygen, but may also be beneficial because of its abilities as an oxygen sensor by modifying the vasomotor tone of the microcirculation. The efficacy of red blood cell depends not only on hemoglobin level, but also on the previous condition of the recipient. And thereby, I think there is a place for the microcirculation in the assessment of the risks and benefit of transfusion. But I think algorithms should be developed first in anemic patients before we can move on to use this in our bleeding patients. And with this, I would like to close and I would like to thank you for your attention.